Hello, everyone. My name is Dr. Pranab Haldar. I'm a respiratory physician in Leicester in the UK, and I manage our TB service here. And today I'm going to talk to you about new evidence that suggests that Mycobacterium tuberculosis, which is the cause of TB, might actually be escaping the lung and into the bloodstream. And in the presentation, I will briefly give you an overview of current TB epidemiology, both across the world and in the UK. And then we'll talk a little bit about what we understand of the pathogenesis of human TB infection and disease at the moment. And of particular interest for this talk will be our sort of increasing awareness that although a disease of the lungs, Mycobacterium tuberculosis does get into the bloodstream, and this is both in people who've got the disease, but also in people who just have the infection. And this might have implications both for what it means in terms of how the infection evolves, and potentially for new diagnostic tools. So you'll all be familiar that tuberculosis is caused by a bacterium called Mycobacterium tuberculosis. It's part of a complex of genetically related species. And we know from the genotypic data of Mycobacterium tuberculosis that it has coexisted with humans for over 60,000 years and actually accompanied humans in their migration out of Africa. What this means is that the organism is very well adapted to the human host, and this makes it a very challenging infection and disease to control and clear. And that's reflected in the epidemiology of TB worldwide, because it remains one of the top causes of death globally. And we know that the majority of TB is focused across certain parts of the world. 8 countries account for approximately 2/3 of global TB incidence now. And these countries are situated primarily within the Indian subcontinent, in Central and Sub-Saharan Africa, and China and Southeast Asia. And TB is actually an exemplar for disease caused by health inequality. So whilst a lot has been made of health inequality and the impacts it's had during the COVID-19 pandemic, this is something that has existed in tuberculosis for a long time. This is also reflected in the history of tuberculosis in the UK. So if we go back 100 years, the epidemiology of TB then looked quite different to what it does now. And at the turn of the 20th century, shortly after the Industrial Revolution was in full swing, tuberculosis rates in the UK were comparable to those that we see in high incidence areas now across the world. And this was driven really by people migrating from rural areas into overcrowded towns and cities, which were growing at the time. And these people were living in very overcrowded conditions with poor sanitation and hygiene. And what we can see from the trends here is that even before antibiotics became available in the 1950s, improvements in general health and well-being and improvements in environment and sanitation led to significant falls in TB rates. With antibiotic treatment being introduced, mortality rates from TB plummeted. And things continued to go in a positive direction really until the mid to late 1980s, when the global HIV epidemic took hold and migration rates into high-income countries actually expanded. So we know from migration trends that the countries affected most by TB at the moment are countries from which a lot of migration occurs into low incidence, high income countries of today. And actually the vast majority of TB in these countries is driven by migration. However, people don't come into a country with TB, they usually migrate having got latent TB infection, and this later reactivates into tuberculosis. In the UK, approximately 70 to 75% of cases we see are in migrants. As I said, I work in Leicester, which is shown here by a red circle. This is in the centre of England and is one of a few TB hotspots around the country. And this, again, reflects the migration patterns into the UK. So most of the TB we see in this country occurs in inner city, multi-ethnic areas with high population density. Leicester is a very ethnically diverse city. And sees, and as a result of that, really sees a lot of TB coming from the Indian subcontinent. So moving on now and thinking a bit about the pathobiology of Mycobacterium tuberculosis infection. As you will know, the infection is transmitted in aerosol, and a susceptible recipient of an infected aerosol will acquire the infection into their lungs. So the organism passes into the lower airways, and because of the size of aerosols, it'll get down into the distal respiratory tract, into what we call the alveolar sacs. And there, the pathogen will encounter various different immune cells. So alveolar macrophages will recognize it as an invading organism, and the first response, the innate immune response, will be to internalize and ingest the organism in an attempt to clear the infection. When it does so, because the organism is so well adapted to the human immune system, a lot of the time the infection cannot be cleared in this way. And an infected macrophage, rather than clearing the infection, simply acquires the infection. An infected macrophage will then stimulate other macrophages to the site of the infection, and together, slowly, they will develop what we call an innate granuloma, which is a cluster of macrophages surrounding a group of infected macrophages. Now, alongside this, there are patrolling immune cells, which include monocytes and dendritic cells, and their role really is to internalize the organism and present it to T cells within lymph nodes. And there the T cells get activated and they come to the site of infection, and a proper granuloma is then formed. So the idea really is that the immune cells, if they're unable to eradicate the infection, will contain it within these granulomas that you can see. And in the vast majority of cases, this strategy is very effective. However, in a small minority, either because of problems with the immune response or because of the virulence of the pathogen, it overcomes the granuloma and the granuloma is disrupted. And this then leads to cavity formation within the lung and allows the bacteria to escape out of the lung and potentially be transmitted to other people. So most of the pathobiology that we know is essentially what is happening in the lung. And that's reflected here in a patient with TB, where you can see large cavities on the chest X-ray, big holes where this damage has occurred. However, we recognize that a significant proportion of people have what we call extrapulmonary TB. So this is disease that affects organs outside of the lung. And in the UK, approximately half of all cases we see are extrapulmonary. So the question really is, how did the TB get outside the lung and into these different organs? The pictures you can see here show an infection in the brain of one patient and in another in the bones near the ankle. So there is plenty of evidence to support the idea that Mycobacterium tuberculosis can escape from the lung to other sites through the bloodstream. So there's the circumstantial evidence that I've just been telling you about, where we know from sites where TB occurs that it must have escaped from the lung, and it could only have done so through the bloodstream. We know that in people who are severely unwell with TB, particularly children and those with severe immunodeficiency from HIV will often have disseminated disease where tuberculosis is, where their whole body is riddled with tuberculosis, and you can often detect the organism and culture it in the bloodstream. And historically, studies in necropsy studies have basically been done, which have identified tuberculous lesions in organs outside the lung in people who've died from TB, but also in people who died from other causes and never had TB during their lifetimes. And in those people of particular interest, when they took some of the extract from the apparent tuberculous lesions and then inoculated susceptible animals, usually guinea pigs, they then also developed a tuberculous lesion, which would suggest that although these people never had TB, they did have viable bacilli that was sitting in organs outside the lung. One of the first reports of being able to culture Mycobacterium tuberculosis from blood comes from 1914. And here, Dr. Faber basically makes some very poignant observations. He notes that it was notoriously difficult and that there were very few organisms which were buried in a mass of red cells and fibrin. And these are inhibitors to achieving a successful culture. And he concludes that it was a matter of good fortune that he was able to show a positive result. So this is not, so although I guess one of the things to sort of take from this is that although we don't routinely detect Mycobacterium tuberculosis in blood, that may not necessarily reflect the fact that it's not there, but more that it's difficult to show. Now, in terms of how the organism gets out of the lung, well, there are two potential pathways. So we know, for example, that the organism is actually transported out of the lung through the lymphatics. And that's shown on the left-hand side, where you can see that the lymphatic drainage in the lungs is usually from the outsides of the lungs towards the center. And eventually the lymphatic ducts will converge on the right to the right lymphatic duct and to the left to the thoracic duct. And these lymphatic ducts will then drain directly into the bloodstream. The other way in which the organisms can get into the bloodstream is actually by directly moving from the alveoli into the network of capillaries that exist as a bed surrounding the alveoli. They're actually in very close proximity to the alveoli, so it wouldn't be a huge step to translocate from within the alveolus to outside. And there's further evidence to support this. So this is on the left-hand side, you can see a recent study which looked at the differences in tissue between a tissue that didn't have, in which macrophages were healthy, and in tissue from mice where macrophages were infected with Mycobacterium tuberculosis. And what these slides show is that infection with Mycobacterium tuberculosis essentially induces what we call angiogenesis. So it induces the proliferation of blood vessels. So this sort of suggests that the infection itself is encouraging blood vessel formation, which presumably is to support its transport out of the lung. On the right-hand side, you can see a CT scan of a human lung where they have drawn on where the blood vessels are. And there's a computer model at the bottom here, which shows that around the granulomas, which are in yellow, there's extensive network of blood vessels seen. So this, again, is in keeping with the idea that infection induces blood vessel proliferation. And going back to the point about, how the organism actually gets away from the lung, there are effectively two ways this could happen. It either walks or it gets a lift. So that's shown here on the left-hand side. So the idea really is that the organism could directly infect the epithelial cells around the alveoli and walk across essentially into the blood vessels at the bottom, or more likely and probably more commonly, the infection basically takes a ride in one of the immune cells, which essentially ingests it and either transports it or tries to kill it. But in failing to do so, effectively acts as a vehicle to carry it outside the lung. And that's shown here on the right-hand side and is known as the Trojan horse theory. So I'm now going to talk to you a little bit about some clinical studies that have looked at Mycobacterium tuberculosis involvement infection. This is a study done in Vietnam in children where they took consecutive people with suspected TB that came into hospital, and then essentially tried to perform Mycobacterium tuberculosis culture alongside routine tests for TB. And they categorized the patients into those who had culture-confirmed TB from sputum, those in whom there wasn't culture confirmation, but they still did blood cultures, and those in whom the diagnosis of TB was unlikely. And what you can see here is that in children where a confirmed diagnosis of TB was made, approximately 10 to 11%, you could find evidence of TB in the blood with culture. If you look at the list of patients that were identified with culture-positive TB in blood, what you find is there's a bit of a theme in that virtually all of them had effectively very severe disease. So they either had meningitis or they had clear evidence of dissemination. So this study kind of brings out some salient points, namely that it's difficult to culture Mycobacterium tuberculosis unless you've got very severe disease and you're very unwell. And that's sort of corroborated in these other studies. So this study on the left-hand side looked at the phenotypes of disease that correlate with a positive blood culture. And you can see here that this wasn't in blood culture, this was actually using molecular methods, but you can see here that the closest correspondence was seen in panel B, which was disseminated TB. In other forms of TB, the association between a positive identification of TB in the blood and having the disease was much poorer. And then on the right-hand slide, right-hand side of the slide, you can see that in patients that have evidence of MTB in the blood, their prognosis in terms of survival is significantly poorer. So this was in an HIV positive cohort, and those who had evidence of MTB in their blood had a higher mortality than those who didn't or who had attended hospital for other reasons. So there has been a meta-analysis published a few years ago now that examined the incidence or the prevalence of Mycobacterium tuberculosis in blood. And what it found was that in terms of culture positivity, the overall rate of detection of Mycobacterium tuberculosis in blood was around 15% in HIV positive adults. In children, the proportions were significantly lower. So again, this is in keeping with the idea that children tend to have a lower sort of bacillary load associated with disease. Now, we've been doing a meta-analysis looking at HIV negative people, so people who are immunocompetent, and this is a meta-analysis that is currently under review, but what it shows is that the yield using culture in these cohorts is virtually zero. But that if you use molecular methods, then studies suggest that you may find a detection rate of up to 15% in HIV negative immunocompetent cohorts with TB. Now, why is it important potentially important to be able to identify MTB in blood? Well, it's another portal for making diagnosis, and this paper I sort of summarized the potential value of being able to do so. So this was in a South African cohort that was predominantly HIV positive, and around a third of patients in this cohort had a positive blood culture. And what the authors report here and describe is that in a population with a high incidence of multi-drug resistant TB, there was value in being able to detect the organism in blood for informing the phenotype of drug sensitivity in people in whom sputum failed. So thinking about this more broadly, we know in our own practice here in the UK that approximately 30 to 40% of people who present to us with pulmonary TB are unable to produce sputum. So having tests that allow us to take samples for diagnostic purposes that don't rely on the patient having to produce sputum could potentially improve our ability to diagnose the condition. And in this case, as an example, by sort of focusing on the pathogen, you're also getting information about their drug susceptibility. So just a few more slides here about molecular methods. So this paper, sort of this result here on the left-hand side, basically shows that the molecular methods that we commonly use in sputum are not optimized really for use in blood. So here, this study looked at whether the expert MTB RIF could be to detect MTB in blood, and this was the first version of the assay, and they compared, and what they found was that essentially 8% of people with culture confirmed TB would be detected in blood using the assay. However, since then, what we've understood is that one of the barriers to using these assays is the fact that red blood cells, fibrin, these all affect the performance of the PCR. And actually, if you're able to use larger blood volumes, then you can improve the sensitivity of the molecular method. So this study here shows that when you increase the blood volume, which is study B compared to study A, you can improve the sensitivity of molecular methods by a considerable margin. And another study here shows actually the other thing that's important, the sort of anticoagulant that you use to collect the blood. So because in the vast majority of cases, the Mycobacterium blood is not actually free Mycobacterium, but within white blood cells, most of these assays focus on collecting the white blood cell fraction of whole blood. And so when collecting whole blood, this study shows that a citrate dextrose-based anticoagulant actually performs better for collecting the blood than EDTA does. And the yield from PCR is increased in that way. So there are clearly steps that can be taken towards optimizing these assays to improve their performance. Now, we've been using an assay called the actophage assay, which is a two-phase blood-based, bacteriophage-based assay to identify MTB in blood. And the way that it works is shown here. So we collect whole blood and then separate out the peripheral blood mononuclear cells. And then this fraction is taken and incubated with a bacteriophage, the D29 bacteriophage, which essentially infects and lyses Mycobacterium tuberculosis, or several Mycobacterium species actually, which are metabolically active. And once the lysis has taken place, the DNA can be collected and cleaned and then run on a PCR to be able to then detect the mycobacterial infection. And this process essentially enhances the sensitivity of an ability to be able to detect MTB DNA in blood. And because it's a phage-based assay, you know that the DNA that you're measuring is coming from bacteria which were metabolically active and viable. And this assay, which was first developed to detect animal mycobacterial infections, we basically collaborated with the inventors to examine whether it works, whether it could work in human infection. So we did a study a few years ago now, looking at patients with pulmonary TB coming to our clinic. So these were pulmonary TB suspects, and we basically stratified them into those where a diagnosis of TB was made and those in whom an alternative diagnosis was made. And we performed the actophage test before they started any treatment. In those who had pulmonary TB, we also recruited their contacts. and performed screening for TB infection and basically stratified them into those who had latent TB infection and those who had no TB infection based on the quantiferon, the interferon gamma release assay. And then they were also followed up for 12 months. So what we found, comparing people with TB with those who presented with symptoms but were found not to have TB, was that actually the assay was very sensitive and specific. So in 11 out of 15 people with pulmonary TB, the actophage assay was positive. And the key differences between patients in whom we got a positive result compared to patients in whom we got a negative result was really in the extent of disease that we could see clinically. So people with a positive actophage result tended to have more disease on their chest X-ray. They had high degrees of inflammation, measuring the CRP, and they had a shorter time to positive culture from sputum. So all of these would indicate a higher bacillary load, and therefore possibly reflecting the fact that there's a limit of detection with the actophage assay that we were achieving in this group. Compared with the non-TB group, where none of the patients that we recruited had a positive assay. So the specificity of the assay in this cohort was 100%. Now, what was also interesting was when we looked at the TB contacts, so those who were positive on the quantiferon test, we had 18 such people, and 3 of them were positive with the actophage test at baseline. These people followed up for 12 months, and 2 of the 3 people who were actophage positive went on to develop TB after a period of several months. So they didn't have active TB at the time they were recruited, and they were followed at 3 monthly intervals for 12 months. So this TB essentially developed during the period of observation, which suggests that firstly, that you can see circulating mycobacteria in people who don't have disease, but also that might tell us about the risk that person has of developing TB in the future. Now, since that publication, there's been another larger publication last year where, using a digital PCR, authors reported significant rates of MTB DNA detection in healthy cohorts who were both IGRA negative and IGRA positive. So these are people who had immunological evidence of TB infection or not. And in both groups, there was evidence that you could identify MTB DNA in their blood. That DNA was predominantly seen in CD34 stem cells, which sort of flux in and out of the bone marrow. And what was interesting was that the proportion of people with a positive MTB, or the prevalence of MTB DNA in blood was higher in people who were quantiferon positive compared to those who were quantiferon negative in those who were HIV uninfected. However, in the HIV infected cohort, that proportion was reversed, suggesting that actually those IGRA negatives were false negatives as a consequence of HIV. So that data all seems to fit together. And the other interesting finding in this study was that after they received treatment for TB infection, the rates of positivity in blood significantly dropped, which would suggest that the DNA that we're seeing here is not just remnants of previous infection, but actually a consequence of existing infection. Now, more recently, we've done a study which is sort of under review at the moment, where we were progressing the idea that identifying MTB DNA in the blood of people with latent infection might associate with increased TB risk. And the way we wanted to evaluate this was using a highly sensitive imaging method called PET-CT, which gives you both structural information, but also metabolic information about activity inside the body. And we've recruited a cohort of recent TB contacts and performed PET-CT scans in them to get information about the status of their infection inside the lungs. Now, these the images we get with PET-CT are much more sensitive than what you can see on a chest X-ray or even a normal CT scan. So it gives you much more information about what's going on. And on that basis, we were able to identify 3 patterns of infection in the lung. So in one group, a small group, there was no evidence of activity, which suggests that even though these contacts had been exposed to TB, there was no evidence of infection, so they hadn't acquired the infection. But there were two other groups, a positive group where there was a considerable uptake and activity, usually in and around the lung, and an indeterminate group where there was a lower degree of uptake, but at sites where you might expect to see TB infection. All of these people had an actophage test done at baseline, and they were all followed up. And those who had a positive PET-CT scan, we also performed sampling from the sites where we saw uptake. So what we had here is in the positive PET-CT group, 4 out of 10 people, actually, we were able to culture MTB from their lymph nodes around the lung, and in one case from the lung itself, from a lavage. And in 7 out of 10, the actophage test was positive. In the indeterminate group, we weren't able to get any samples or positive cultures, but 4 out of 6 people in that group were actophage positive. And in the negative group, we had 1 positive actophage test. We then looked also at performing, so those who had a positive Mycobacterium culture from the lung, we treated for TB infection. In the remainder, we performed a second PET-CT scan after 3 months and didn't give them treatment and simply followed them up on that basis. And in those people where there was evidence of progressive change over that 3-month period, we then concluded that they had a progressive form of MTB infection, and we then decided to treat them. Now, when we compared the actophage positive group to those who were actophage negative, we found a significant association between having a positive actophage test and having either a positive culture following a PET-CT scan or evidence of progressive infection when you perform serial PET-CT scan, which suggests that actually being able to detect MTB in the blood correlates with an increased risk of developing disease. So essentially correlates with potentially a higher bacillary burden and a higher risk of progressive infection. So really, to summarize and conclude then, what we can say is that human MTB infection is very complex. It starts in the lung, but is likely to be more widespread than we currently appreciate. There is emerging evidence that MTB can escape into the bloodstream more often than we think, and actually in a wider spectrum of infection than we previously appreciated. So that includes both immunocompetent and immunocompromised cohorts with TB, but also cohorts that just have the infection and not the disease. And our data also suggests that the mechanisms leading to dissemination may be different according to whether it occurs as part of infection or whether it occurs as part of disease. And this is a piece of work that's ongoing at the moment, but it's really quite clear that our perspective that TB is simply a disease of the lungs may not be necessarily entirely accurate.